So it says here that I am presenting I think I see my presentation there.
Yes, we see it now.
Okay, great.
Thank you.
So I'm currently the Chief Surgical Officer at the American Hospital in Tbilisi in the Republic of Georgia. Just to go through my disclosures, I'm the Editor-in-Chief of a journal called Artificial Intelligence Surgery. I'm the CEO of a startup called Talos Surgical that focuses on autonomous action. I'm also a consultant for Moon Surgical, which is a company that does a complete robotic surgical system that does not have a console, which we'll talk about later. And I'm also on the advisory board of SS Innovations, which I believe I'm going to show a picture of later, of the Mantra robot. So this is where I do my artificial intelligence research at the University of Magdeburg in Germany. It's about an hour west of Berlin, a beautiful center. I encourage you to go. The technology over there is amazing. We're going to talk a little bit about one of the first editorials that we published in the journal called What is Artificial Intelligence Surgery? And we're going to kind of go through the definitions of autonomous actions in surgery and their comparisons with autonomous actions in autonomously driving cars, okay? First off, people have a hard time, including myself before I started doing this research, on the difference between automatic actions and autonomous actions. You know, automatic actions are you hit a button and something happens. Autonomous is there is some independent decision making, some sensor, some analysis, some interpretation that happens before the action actually occurs. So the best way to understand this is when we look at the 6 levels of surgical autonomy, again, as I mentioned, that are based on the 6 levels of autonomously driving cars. Level 0 designates no autonomy, easy to understand. Level 1 is defined as telemanipulation of a robot. So the Da Vinci, the CMR robot, the Mantra robot by SS Innovations, those are all just telemanipulators, very low level of autonomy. So one of the reasons why I've been less enamored by these complete robotic systems is that they actually have a very low level of autonomy. And I'm more interested in things like level 2 autonomy, which corresponds to a limited autonomous action, and we'll talk about some examples shortly. Level 3 is defined as conditional autonomy, where the surgeon selects among several autonomous actions that the robot or the device can perform. Level 4 are autonomous actions that include automated medical decision-making, but still under a doctor's control for part of the procedure. And level 5 indicates full autonomy when no human control is necessary. When people think about artificial intelligence surgery or autonomous actions in surgery, they think level 5. But you know, we really have to start to understand that there's many different levels that we have to master, you know, before we should get to level 5. But the reality is that I'm going to show you that we actually have examples of level 5 already in healthcare. So level 2. Level 2 autonomy, an example would be the Signia robot handheld GIS stapler device made by Medtronic. It has a sensor inside it. Unlike its competitor, which is just an automatic linear device, this device has a sensor. If the tissue's too thick, it'll slow down before it cuts. If it's not thick enough, it won't fire at all. So there is something going on there. Now, Ethicon has a circular stapler that has a similar sensor, and on the contrary, Medtronic has just an automatic one. So that's why it gets a little bit complicated when we start to think about these powered staplers and what type of level of autonomy that they have. Another interesting, I think the most interesting thing that the Da Vinci has, it has a table that as you move it, the robotic arms move autonomously. And this is a beautiful example of level 2 autonomy. And it actually, I repeat, what impresses me the most about the Da Vinci platform. I have a video of that, but we don't have time for that. So level 3, this is an example of this would be the ligature device. It's a vessel sealing device. Depending on how big the vessel is, the machine determines when you're ready to transect the vessel, right? You're just sitting there holding the button, and then the machine tells you. How does it do that? It looks at 434,000 data points per second, and you have 3 different buttons, depending on how large you think the vessel is, and how much, essentially, cooking that it needs. And it, again, I repeat, you know, the surgeon's controlling it, the surgeons have multiple options, but this is a nice example of level 3. Level 4 would be something like a device that does a cardiac ablation. The intervention cardiologist goes into the patient's vessel, snakes up the device. The device is in the right atrium. It detects where there's improper electrical activity, and will do the ablation by itself, still under the doctor's control. Okay, so level 4 already exists. Now, level 5, does it exist? I basically just told you the answer. Of course it does. In an AICD, an automated implantable cardioverter defibrillator, it detects a life-threatening injury and gives a life-saving treatment, all without any input from a doctor. So this is a beautiful example of level 5 autonomy in healthcare. So, we all need to realize that level 5 autonomy has been around for decades. Not only is it a recent development, but it's also a development that's been around for decades. So we need to prepare for this, that this exists. And if we don't have doctors that understand the nuances of this technology, we're going to have healthcare companies pretty much shove things down our throat, and I think it's very dangerous, which is why I became very interested in this topic. So this is a white paper that we published with the journal on the definition of artificial intelligence and autonomous actions in surgery, if you're more interested in the topic. But as you've noticed, my topic is autonomous endoscopic navigation. So this is a scoping review that we did. And the reason we did it is we wanted to figure out what is the best path towards autonomous action in surgery. And we actually believe that the best way is if we automate things like endoscopic surgery, notes, procedures, what have you. If we automate things like percutaneous surgery, imagine a robotic arm that can find a liver tumor and do the ablation autonomously. But we also think things like handheld robotics are a nice, safe way to develop more autonomous actions in the actual operating room, and non-console complete robotic surgical systems like the Moon Surgical, where the surgeon is in contact with the patient at all times. So let's talk a little bit more about this. This is the review article on AI and endoscopy. AI and endoscopy can be broken up into two things, really. The autonomous interpretation of the image. The detection of polyps is basically a simple way of understanding this. And there's many things on the market already that can do this, where the endoscopist does the colonoscopy, the image is recorded, and in real time, the AI can interpret what is being detected, what is being seen, the probability that things are cancers or what have you. So these are just multiple examples of that. This just shows you the review method that we did. We found 24 studies that talk about the concept of AI in endoscopy, talking about, again, computer vision interpretation, but also there's some papers on robotically assisted flexible endoluminal endovascular systems. Right, there are multiple ones. I'm not going to go through all of them, but I do want to point out the vascular catheter, CorePath GRX. So this controls the trajectory of coronary guide wires using magnetic interpretation and a magnetic system. The other ones, such as the Horus system, we'll show a picture, but these are really still just telemanipulated systems. But again, it's level 1 on the way to full autonomy. So this is just an example of the Horus system. This is used for bronchoscopy. As you can see, it has 2 robotic arms, and this is already being manufactured and being used. But as you can see, it's really just a telemanipulator where the bronchoscopist or the thoracic surgeon controls the device. But really, this is the first iteration, and as newer navigation methods are developed, fully autonomous navigation during endoscopy is really probably going to occur in our lifetime. So this is a paper from the Lancet talking about fully automated magnetically controlled capsule endoscopy, which I'm sure many people know about. I think with a robotic arm on the outside controlling the capsule endoscopy. This is another example of something that can be pretty easily automated, rendered autonomous. But I also wanted to talk about this, where you have a colonoscope that is dragged through the colon with an external magnetic arm that is pulling it through the colonoscope. So multiple teams are working on this. One of these papers, the image on the right, was published in Nature. So as you can see, autonomous endoscopic navigation is very, very real and is being developed at a lightning pace. So I just want to go back to talk about what complete surgical systems we are. This is a surgical conference. I am a surgeon, so I just wanted to go over quickly the types of robotic systems that there are so we can better understand handheld robotics and non-console robotics. So most devices are telemanipulators. They have multiple arms with Da Vinci, like the Mantra robot from SS Innovations, but this one has separate arms. CMR, which has a similar setup to the Mantra. But you also have Avitera. Not all of these still exist, but I just want to go through them. Bitrack, multiple arms. SetHands, multiple arms. The Medtronic system, Dexter. But then you also have single port systems. The Intuitive has a single port system. Vicarious, Enos, Mira, but again, all telemanipulators, all level 1 autonomy. Now you have endoluminal systems, a little bit like the Auris, but these are specifically done for more surgical procedures, if you will, transorally or transanally, and these are just other companies that have that. Now, to understand the potential of robotics in the future, I use the example of Star Trek or Star Wars. Do we want a future where the endoscopist, where the surgeon is at the bedside in contact with the patient? This is an example from Next Generation. Or do we want something like is shown in Star Wars, where there's just a robot and a patient, unfortunately, screaming on a table because apparently there's no anesthesia in the future. So which one do we want? To answer this, we wrote a paper called Keeping Surgeons in the Loop that discussed handheld robotics, comparing hepatectomy for colorectal liver metastases versus hepatectomy for patients that had surgery with the Da Vinci system. We found quite a few advantages with surgery that was done with handheld robotics. The bottom line was the vast majority of surgeries could be done minimally invasively when handheld robotics were done, but on the order of about 87%. And only about 50% of surgeries could be done with the Da Vinci robot when hepatectomies could be done when the Da Vinci was done. So this is just an example of how handheld robotics potentially has an advantage. Obviously, you maintain haptics. These are just some examples of some other handheld robotics. This is the Jamie system. Handex also has one, and there's another one called Dex Surgical in France. But you also have autoclavable laparoscope holders. And we already talked about the Signia. But what about non-console robotics? And I want to tell you quickly about the term cobots, which is short for collaborative robots. So are these handheld robots, are they more collaborative robots? Is the Moon Surgical, the Maestro system, a collaborative robot? Should Da Vinci also be considered a collaborative robot or a cobot? Who knows? This is an example of the Moon Surgical device. It has 2 robotic arms assisting the surgeon, one holding the camera, one holding the retractor. The surgeon's at the bedside, maintains haptics. Now you can imagine the Jamie system, where you have 7 degrees of articulation, degrees of freedom, and robotic arms supporting those 2 surgical instruments. You can have a very powerful device. It's obviously cheaper, there's no console, and again, you maintain haptics. Maybe this would be the best way to get more autonomy, more autonomous actions in surgery. So I think a mixture is probable as far as the future. I think the Da Vinci is great for pelvic surgery in particular. I think the Versius and the Mantra have fewer setup options and have some advantages because you can use the same incisions that you do when you do laparoscopy. You don't have to put your incisions lower like you do for the Da Vinci, which has 1 arm, its latest iteration. But I do think we need to look at non-console and handheld robotics much more, particularly when we have to do things like vascular reconstructions. So this is just to show you what's commercially available as far as autonomous actions. We have vessel sealing, we have stable and anastomotic lines, we have motion scaling and tremor reduction, we have organ segmentation. We also have autonomous laparoscope tracking, where the camera follows an instrument and you don't even have to control that. In the prototype phase, we have autonomous aspiration, retraction, debridement, suturing, like the Star robot that's being developed at Hopkins. We also have autonomous knot tying. There are also prototypes now for situation awareness and phase recognition, so I have to update my slide. But autonomous pneumoperitoneal access, actually I just found out has a prototype also. The one that doesn't have a prototype, really the only one now, is autonomous dissection. So this is just a Geithner hype cycle that talks about the path towards more autonomous action. It was written in a paper we published in Sensors, a review article on autonomous action. I'm sure I don't have enough time to go into this, but I encourage you to go to that paper if you're interested. So I just wanted to finish by letting everyone know that autonomous surgery is a reality. It should probably focus on percutaneous and endoscopic surgery first, but other forms of robotics in the operating room should be explored, such as handheld robotics and non-console complete robotic surgical systems. Thank you very much for your time.
Thank you, Dr. Andrew. It was an excellent demonstrative lecture. I hope we can have 2 questions from the floor. Are you with us, Andrew?
Yes, I hear you, of course.
We have a question here.
Okay. Good morning, Andrew and the panel. My name is Mohammed Foda. I'm a specialist in general surgery and urology. I'm a Canadian Egyptian, and I want to ask you, knowing exactly how difficult it is with litigation in the U.S., where does the liability lie when problem is produced by the autonomous machine? 2, what's the cost versus benefit merit of all these endeavors? Thank you.
Sure. So, you know, I must say I'm pretty happy to no longer work in the United States. So you'll have to answer that question for yourself. I do know in places like Europe and places like the Caucasus region, if you have a problem with a device and you can show, for instance, the ligature or the Da Vinci causes a burn, you know, the problem, if it can be identified as a technical problem, then it's the problem of the manufacturer. If it's a problem detected with, you know, the surgeon, it gets determined by the surgeon. So it really has to be decided on a case-by-case basis. I mean, if you have a stapler fire that misfires, you know, if you can show that it's the manufacturer's problem, it's the manufacturer's problem. If it's not, you know, regardless, you have to know how to deal with the complication. And that is usually the main problem with these things, is that the complication isn't identified in a timely fashion. As far as the cost savings or the cost of all of these things, you know, I'm particularly interested in autonomous colonoscopy because about 60% of the world has no access to colonoscopy. Because, you know, we can completely cure colorectal cancer if we had people getting surveillance in a proper way. We could eliminate almost a million deaths per year, much like COVID. But we don't have the endoscopists, and autonomy could fix that, right? If we had an autonomous colonoscopic system, that it could completely fix that. So I'm not sure that cost in that regard is really relevant if you can save 1 million lives per year. I mean, think about the money that we spent for COVID during the pandemic. But I do think things like cost with robots and complete surgical systems, it's a slightly different topic than the one you mentioned. But I do think it's an argument for the handheld robotics, the robotic systems that don't have a console that are cheaper, because I think more people could benefit from robotics. So it's a very quick answer for a very complex question that you asked. Hopefully it sheds some light on it.
Thank you. He has another question for you.
Yep.
Just a comment about a legal liability when a surgeon is confronted with a deep pocket corporation trying to say it's the corporation's fault. It's going to be la raison du plus fort est toujours la meilleure, meaning the reason. Okay. You can stand in front of a big corporation, so the surgeon's liability is not proportionate in this case. Thank you.
Well, I mean, that's already occurring with the Da Vinci, right? I mean, I know Da Vinci has had, you know, quite a few lawsuits. I don't know the resolution of those lawsuits, but all surgical devices have a little bit of this problem. I mean, think about the meshes that were put in. these are big legal questions, and I don't have the answer because surgeons were putting in the pelvic meshes, right, for the uterine prolapse, and I know the companies took a big hit, but I'm sure the surgeons also unfortunately took a big hit. That is unfortunately a massive legal question that you're asking. But I don't think that's the reason to not use autonomy. That's not a good reason in my mind to use artificial intelligence, because there are too many people without access to healthcare at all. We have people with disabilities who rely on artificial intelligence to make their lives better. So just sticking our head in the sand and being afraid of advancements, I don't think is fair or the right answer. I mean, it definitely has concerns. We write a lot of paper on the ethics of AI, and I think it needs a lot of research, but I see a tendency in the United States to shy away from AI research and to suppress it. And what I've seen happening is developments are occurring, in places like China and Russia, and they're becoming the world leaders in some of these technologies. So, it's a complex question about what to do, but I stress putting our head in the sand and resisting change and advancement is going to end up biting the United States and Europe potentially in behind, in my opinion.
Thank you, Andrew, for your contribution. If you have time, you can tell us when or about your second talk. We can let you anytime today till 4 p.m. Okay?
Great.
Okay. Thank you very much.
Thank you, everyone. Bye-bye.
Bye-bye.